Welcome to the weekly Neurology Deep Dive. This program is produced by Amer Gavanini.
Hello, everyone.
And please note clearly and early that this deep dive is strictly for educational purposes. It has no commercial goals.
Exactly.
It is only a summary. So you are strongly recommended to read the full paper we are discussing today.
Which is a very interesting one.
It really is. I will formally cite the paper now. It is a systematic review by Shane Zhang and colleagues, published in Neurology Open Access in 2026, titled N-Acetylcysteine in the Treatment of Ischemic Stroke.
And before we jump into the complex biochemistry and the clinical trials, here is a bottom-line practical summary for you, specifically for the busy neurologist heading into your next shift.
Please.
N-acetylcysteine shows fascinating biological promise. It acts as both an antioxidant and an anti-inflammatory neuroprotectant in the setting of acute ischemic stroke.
But what does the data actually say?
Well, when you look across the 4 clinical trials included in this review, involving 194 patients, the data shows significant but highly inconsistent improvements in NIH stroke scale scores.
And biomarker profiles as well, if I recall.
Exactly. The functional outcomes on the modified Rankin scale also yielded mixed results. As for safety, the profiles are generally acceptable.
Though there was that one study.
Yes, one specific study reported fatal hemorrhages. But importantly, that was without a control group. Crucially, because only 2 of these studies included modern reperfusion therapy, the evidence remains highly preliminary.
So no immediate changes to practice.
Precisely. Its use is absolutely not yet recommended for routine clinical practice.
I see. So, the natural question many clinicians ask is why the neurology community continues this decades-long hunt.
The hunt for neuroprotectants to freeze the penumbra.
Exactly. We already possess highly effective reperfusion therapies. I mean, we have recombinant tissue plasminogen activator, and we have mechanical thrombectomy.
We do.
With these powerful tools to open vessels, why dedicate so much research to finding an additional pharmacological intervention?
Well, what makes this pursuit necessary is the sheer speed and the absolute destructiveness of the ischemic cascade. I mean, stroke remains the second leading cause of death globally.
It is devastating.
It is. When a cerebral vessel occludes, the tissue in the penumbra does not instantly evolve into irreversible ischemia. There is a precious, fleeting window.
But during that exact window, things go terribly wrong at the cellular level.
Precisely. Excessive glutamate release causes a massive overactivation of ionotropic glutamatergic receptors, specifically the N-methyl-D-aspartic acid receptors.
And that overactivation essentially flips a destructive switch.
Exactly. It results in a catastrophic production of free radicals within the neural tissue. Furthermore, and this is the terrible paradox of stroke neurology.
Reperfusion itself accelerates the damage.
Exactly. It accelerates the damage caused by these free radicals, ultimately leading to irreversible neuronal cellular death.
So the actual return of blood flow, the very thing we are desperately trying to achieve with a thrombectomy or thrombolytics, can act like pouring gasoline on an existing cellular fire.
That is a perfect way to visualize it.
So let us explore the chosen intervention. Why was N-acetylcysteine specifically selected from the vast array of potential pharmaceutical compounds to intervene in this cascade?
Well, the selection is largely driven by its unique chemical properties and its proven track record. N-acetylcysteine is already recognized by the World Health Organization for diverse applications.
Like breaking up mucus in respiratory conditions.
Exactly, or treating paracetamol poisoning. But in the specific context of the human brain, it serves as a direct precursor to L-cysteine.
I see.
By providing L-cysteine, it demonstrates proneurogenic and neuroprotective properties because it dramatically increases the levels of glutathione.
And glutathione is an endogenous antioxidant, absolutely crucial for defending cells against severe oxidative stress.
Precisely.
But, there are other precursors out there. What makes this one special for neurology?
The critical difference is permeability. Unlike other precursors to glutathione, N-acetylcysteine effectively penetrates the blood-brain barrier.
Oh, fascinating. So it actually gets to the target.
It does. Once it crosses over, it essentially operates with a powerful dual action. First, it acts as a direct antioxidant. It directly neutralizes those free radicals and aggressively scavenges reactive oxygen and nitrogen species.
And the second action?
Second, it exhibits potent anti-inflammatory properties by modulating the nuclear factor kappa B pathway.
When you mention the nuclear factor kappa B pathway, you are essentially talking about the master genetic switch for inflammation.
Precisely.
So we can envision N-acetylcysteine acting as a chemical fire blanket. The primary clinical objective is to throw this blanket over the ischemic penumbra to smother the oxidative stress and suppress the inflammation.
That is the goal.
Ultimately, you are just buying precious time before the fire department, meaning physical recanalization finally arrives on the scene.
Exactly.
But I have to push back here. That fire blanket analogy sounds fantastic in a preclinical animal model.
Yeah.
My hesitation revolves around real-world translation. We know theoretical biology often looks flawless in a petri dish.
It often does.
So does this dual-action mechanism actually hold up when a human stroke patient is lying in an emergency department bed?
Well, that is the pivotal question of this entire systematic review. Testing the theoretical fire blanket against actual patient data reveals a highly complex, sometimes contradictory, clinical picture.
Let's get into the numbers.
So review compiled data from 194 participants spread across 4 distinct trials. When we examine the NIH stroke scale data, we see tremendously varied findings that require careful interpretation.
Give me an example.
For instance, one trial utilized an oral loading dose of 4 grams. That specific trial demonstrated a significant median decrease of 6 points for the N-Acetylcysteine group.
Wait, a 6-point decrease?
Yes, compared to only a 2-point decrease for the placebo group at the 90-day mark.
A 6-point drop on the NIH stroke scale is a highly meaningful clinical change for a patient's trajectory. But that was an oral dose. What happened in the other trials?
Well, another trial utilized an intravenous bolus. That trial found absolutely no significant difference in the NIH stroke scale at 24 hours.
None at all.
None. Interestingly, as they followed those patients, they observed significant improvements at 2 weeks and 1 month, but they completely lost that statistical significance by the 3-month mark.
That is puzzling. What about the third trial?
A third trial evaluated patients receiving intravenous recombinant tissue plasminogen activator. That one showed a significantly lower NIH stroke scale score at 24 hours compared to the control arm.
So if the bedside clinical scales are giving us this kind of whiplash, we really need to dig into the long-term functional outcomes.
Definitely.
As practicing neurologists, an early reduction on the NIH stroke scale is certainly valuable. But achieving functional independence at 90 days is what truly dictates the patient's long-term quality of life. Tell me about the modified Rankin scale data.
The modified Rankin scale data presents an equally mixed narrative. The trial, utilizing the oral administration, found a significant improvement at 90 days.
How significant?
They observed favorable scores, which they defined as a modified Rankin scale score of 0 or 1, in about 58% of the N-acetylcysteine patients.
In the placebo group.
That is compared to about 29% for the placebo group.
Doubling the rate of a favorable outcome is massive. But I imagine there's a caveat coming.
There is a severe caveat. In stark contrast to that oral trial, another trial evaluating intravenous administration found no significant difference in functional outcomes at all.
Oh, I see.
They reported favorable outcomes in about 74% of the intervention group versus about 76% for the control group.
The chronological inconsistency across these findings is glaring. I mean, a pharmacological intervention demonstrating a significant clinical benefit at 1 month, but completely failing to show a significant difference by 3 months, is highly problematic.
It is difficult to interpret.
Does this chronological inconsistency fundamentally weaken the underlying argument for clinical efficacy?
Well, it does not necessarily weaken the underlying biology, but it raises an incredibly important question regarding the true durability of neuroprotection.
What do you mean?
Think about the mechanism. If the intervention merely delays cellular apoptosis rather than preventing the cell death entirely, those early, exciting gains observed on the NIH stroke scale at 2 weeks or 1 month might naturally fade away by the 90-day evaluation.
Oh, fascinating.
You are not permanently saving the neurons. You are just placing them on a temporary cellular life support.
Wait, so you are saying the neurons might still be doomed, just on a slightly delayed timeline?
Exactly.
That's a profound concept. If we are only delaying apoptosis, it completely alters how we should interpret 30-day clinical trial endpoints in neuroprotection.
Precisely. Furthermore, the varying dosages, the different administration routes like oral versus intravenous, and the diverse concurrent standard of care treatments across these relatively small clinical trials introduce substantial noise into the data.
I can imagine.
That sheer heterogeneity makes it exceedingly difficult to draw a unified conclusion regarding long-term clinical efficacy from just 194 patients.
Because the macroscopic clinical scales are undeniably mixed, maybe we need to look closer at the cellular level. We need to determine if N-acetylcysteine is actually performing its intended molecular tasks within the hostile ischemic microenvironment.
Or if it is just washing through the brain without having an effect.
Exactly.
Well, the biochemical data actually provides compelling evidence of localized biological activity. A 2020 trial evaluated multiple serum biomarkers and showed significant increases in enzymatic antioxidants at 72 hours.
Which is specific antioxidants.
Specifically, they measured significant increases in glutathione peroxidase, total thiol groups, and superoxide dismutase.
We can think of an enzyme like glutathione peroxidase as a molecular sponge, actively mopping up those catastrophic reactive oxygen species generated during the stroke.
That is a great analogy.
Seeing those levels spike at 72 hours confirms the drug is acting exactly as intended.
It does. And in tandem with those antioxidant increases, they observed significant decreases in melandialdehyde.
And melandialdehyde serves as a highly reliable clinical marker of lipid peroxidation.
Exactly. They also noted significant decreases in interleukin-6, a well-known pro-inflammatory cytokine, and another trial demonstrated a significant reduction in the total oxidant status at 24 hours.
Here is where the specific mechanisms of action get genuinely fascinating. A 2025 trial evaluated intravenous alteplase combined with intravenous N-acetylcysteine, and they measured its direct effect on coagulation pathways.
Yes, that 2025 trial specifically analyzed von Willebrand factor multimer sizes. This is crucial because these multimers orchestrate platelet adhesion.
What did they find?
At 3 hours post-treatment, the combination of alteplase and N-acetylcysteine led to significant reductions in plasma concentrations of ultra-large molecular weight multimers by about 81%.
That is substantial.
And high molecular weight multimers by about 83%. Consequently, the low molecular weight multimers increased by about 83%.
If we visualize those ultra-large multimers as thick biological spiderwebs trapping platelets and worsening microvascular occlusion, the intervention is actively cleaving those webs apart.
Precisely.
This is essentially looking under the biochemical hood and seeing the engine turn over perfectly. The biochemistry is clearly responding to the intervention.
It certainly is.
I have to push back from a strictly clinical perspective, however. Do these transient biochemical changes matter at all if they do not consistently translate to a patient recovering their long-term functional independence?
Well, if we connect this to the bigger picture, transient biochemical changes are only valuable if they successfully bridge the gap to definitive treatment.
Exactly.
A temporary reduction in von Willebrand factor multisupers or a 72-hour spike in glutathione peroxidase proves the drug is reaching the target tissue and actively altering the hostile microenvironment. It is doing its job. But your clinical skepticism is entirely justified. If those hard-won molecular victories do not ultimately result in preserved brain tissue and a demonstrably better modified Rankin scale score at 90 days, they remain fascinating laboratory phenomena rather than genuine clinical triumphs.
Exactly. A beautiful biomarker profile does not help a patient walk or speak again. And if N-acetylcysteine dynamically alters the biochemistry and potentially impacts these clinical scales, the immediate next priority for any practicing neurologist is rigorously assessing its safety profile.
Absolutely.
This evaluation is especially critical in the modern era of aggressive reperfusion therapies, where bleeding risks are already elevated.
The safety data outlines a profile that is generally acceptable, but it carries severe caveats that demand our attention.
Tell me about the general adverse events first.
One trial noted significantly higher rates of nausea, dyspepsia, and headache among the treatment group, but they reported absolutely no serious complications.
What about the other trials?
Another trial found moderate adverse reactions in about 5% of the total cohort, demonstrating no significant difference in the rates of intracerebral hemorrhage or extracranial bleeding when compared to the standard of care control group.
That sounds reasonable.
It is also worth noting the fundamental differences in administration routes. Nausea and vomiting appear more common with oral N-acetylcysteine, while anaphylactoid reactions are historically more associated with the intravenous route.
You mentioned severe caveats. You were exactly on point to bring up the 2025 trial because the safety profile documented that specific study is a massive red flag.
It is. The 2025 trial was terminated early after enrolling only 12 patients due to severe safety concerns.
Just 12 patients?
Yes. Within that exceptionally small cohort, they reported 2 fatal symptomatic intracranial hemorrhages and 1 instance of anaphylactoid shock.
2 fatal hemorrhages out of 12 patients is alarming. especially when evaluating a drug intended for routine use alongside thrombolytics.
It is alarming, but I must explicitly clarify the context of those events. This specific study lacked an in-trial comparator group entirely.
I see.
Furthermore, both patients who suffered the fatal hemorrhages were previously taking aspirin, adding another layer of bleeding risk.
So the baseline risk was already elevated.
Exactly. Additionally, the pre-treatment NIH stroke scale of this specific cohort was markedly different from the historical controls they were compared against.
So it was an unequal comparison.
Because of these substantial confounding variables, we cannot draw reliable conclusions regarding direct causation. We cannot definitely state the intervention caused the hemorrhages, but we cannot ignore the signal either.
Beyond safety, we face the reperfusion problem within this systematic review. This issue threatens to completely undermine the clinical applicability of these findings for a modern stroke center.
The authors emphasize a major limitation of their own systematic review. Only 2 of the 4 included studies evaluated N-Acetylcysteine in the context of modern reperfusion therapy.
Meaning the administration of recombinant tissue plasminogen activator or the performance of mechanical thrombectomy.
Exactly. The other trials deliberately excluded patients who were candidates for these standard interventions.
Neuroprotection without recanalization is frequently a dead end. How does the complete lack of reperfusion in half of these analyzed trials impact the generalizability of this systematic review for stroke units operating today?
It severely limits the generalizability of the findings. In contemporary neurology, our baseline standard of care revolves entirely around opening the occluded vessel as rapidly as possible.
Certainly.
Testing a neuroprotectant without attempting reperfusion is studying a clinical scenario we actively work to avoid. Going back to your earlier analogy, if the drug acts as a fire blanket, it merely slows the rate of neural destruction.
Right. I mean, without the fire department ever arriving to restore cerebral blood flow, the ischemic tissue under that blanket will inevitably succumb to infarction.
Exactly. Therefore, the trials omitting reperfusion therapy do not accurately reflect the complex, hyperacute patients you are treating daily.
That makes perfect sense.
Furthermore, some of these studies suffered from exceptionally small sample sizes, ranging from 12 to 74 participants. That size drastically increases the risk of a type 2 error.
Where a true clinical benefit might exist, but the trial is simply too small to statistically detect it.
Exactly.
Yeah.
One trial even excluded patients with a severe stroke, which they defined as an NIH stroke scale greater than 22. That introduces clear selection bias into the data pool.
We have to view this within the broader historical context of our specialty. The systematic review mentions other neuroprotective agents that have been evaluated over the years. We have seen a long, frustrating history of failed trials in this domain.
The pursuit of neuroprotection is filled with immense promise, followed by bitter disappointments.
It really is.
The paper references the Phase 3 trial for silvataltide, which demonstrated favorable results with lower modified Rankin scale and NIH stroke scale scores at 90 days. Conversely, it highlights the Urico IC2S trial.
I remember that one.
That was a Phase 2b trial, which found that uric acid provided no superiority to a placebo in patients treated with alteplase, despite possessing a highly plausible antioxidant mechanism.
What does the failure of uric acid teach us? It suggests that a theoretical antioxidant mechanism is not enough on its own to salvage brain tissue.
Precisely. The development of a suitable neuroprotective agent should not be viewed as a race for a single, miraculous monotherapy. The ischemic cascade is too complex and multifaceted.
So what is the alternative?
N-Acetylcysteine might eventually exist within a broader treatment framework alongside other pharmacological agents. We might need a sequential approach, sequentially targeting the distinct stages of ischemia.
I see.
You might need one agent for early excitotoxicity, N-Acetylcysteine for the subsequent inflammation, and another entirely different compound to permanently halt apoptosis.
So if you had to distill all of this complex data, the transient biomarkers and the conflicting clinical scales down for a clinician heading into the stroke unit tonight, what is the final takeaway? Please reiterate the bottom line practical summary for our listeners.
While N-Acetylcysteine successfully elevates brain antioxidants and shows some significant but fluctuating improvements in NIH stroke scale and modified Rankin scale scores, the current data is drawn from small, highly heterogeneous trials.
And the safety aspect.
Its safety profile is generally acceptable, though extreme caution is warranted given the isolated reports of fatal hemorrhage when combined with thrombolytics. Ultimately, until much larger, well-powered clinical trials evaluate N-acetylcysteine specifically in conjunction with modern reperfusion therapies, it is absolutely not recommended for routine clinical use in acute ischemic stroke management.
That sets a very clear, evidence-based boundary for current clinical practice, while smartly leaving the door open for future, more rigorous research.
It does. Which leads me to a final thought for you to ponder long after this deep dive ends.
Please share it.
If neuroprotectants like N-acetylcysteine serve best as a temporizing measure to preserve the ischemic penumbra and delay cellular death, perhaps we are administering them too late in the clinical pathway.
How early should we go?
Should future stroke networks focus their efforts on administering these agents in the ambulance before the patient even reaches the hospital's computed tomography scanner?
Fascinating.
Maximizing the window for neural salvage might require paramedics throwing that chemical fire blanket over the brain the very moment they arrive at the patient's door, ensuring the delicate neural tissue survives just long enough for physical recanalization to truly matter.